screen and the recording.
So,
Noah, do you remember those two things?
yes, Professor.
And I'd like to welcome Noah Harkness. He's a senior at King University from Toronto, Canada. He's a double major in both physics and math and a member of the golf team at King. He'll be transferring to undergraduate engineering in Canada this fall. Please welcome Noah Harkness.
Well, thank you for that introduction, Professor Sutherland. And my presentation is entitled Artificial Intelligence and its Applications to Analyzing Mammograms for the Detection of Breast Cancer. And I chose this topic because I first took a course in medical physics last year with Professor Sutherland, and I learned about medical imaging. And then last summer, I spent some time with some data scientists who were working on an artificial intelligence application to look at breast density on mammograms. So unfortunately, their research got delayed, so I wasn't able to participate as much as I wanted to, but I'm still interested in AI. So my hypothesis is that artificial intelligence has great potential for transforming the way that radiologists interpret mammograms. So here's my outline, and I have a lot to cover, so I'll just mention my topics briefly. So first, I'm going to give a general overview of AI and how it ties into radiology. And then I want to give some background about breast cancer and mammograms. And then I'll talk about an early form of artificial intelligence called computer-aided detection, or CAD. And then I'll talk about more advanced AI applications for mammograms. And then I'll end off with limitations and future directions of AI. So I'll start off with the general overview of AI. So artificial intelligence is a term that we're all familiar with, but in terms of a definition, it describes tasks that are performed by computers that ordinarily require human intelligence. And machine learning is a subset of AI, which is the ability of the computer to learn without being explicitly programmed. And deep learning is a subset of machine learning, which teaches a computer to filter inputs through layers that can recognize complex patterns. So on the left is a diagram of a simple neural network, which forms the basis of AI and machine learning. And then on the right is a deep learning neural network with an input and many hidden layers and a final output layer. So it functions much like the neurons in the human brain, where each neuron is triggered by another neuron, and then its output can trigger other neurons in return. So the computer can start by recognizing lines and shapes and then move on to more complex patterns as it moves along the neural network until there's a final output, like recognizing a cancerous mass. So now I'll talk about AI and how it ties into radiology. So radiology is well suited for AI because of the large amount of digital data that comes from images. And the input in radiology is always the image, and here we have an X-ray of a hand. So traditionally, the radiologist reads the image and gives the output as either a normal or abnormal result, like a fracture in the hand. And in AI, the computer gives the output and can either say the output is normal or abnormal. And the advantage is that the computer does not get tired and it's not prone to human error. So here are some of the ways that AI could be used in radiology. So first, there could be a triage system where AI sorts out images into normal and abnormal, and the radiologist only interprets abnormal results with or without additional AI. Or AI could act as an add-on, where first the radiologist sorts out normal and abnormal, and then the AI interprets abnormal results. And finally, AI could act as a replacement, where AI interprets images and there's no radiologist involved. So now I'll give a background about breast cancer and mammograms. So breast cancer is a very common cancer, and in fact, 1 in 8 women will be diagnosed with breast cancer in her lifetime. So a mammogram is a screening tool to detect breast cancer. So this means that healthy women go for the test when they don't have any problems with their breasts. And it's a low-dose X-ray where breasts are compressed between plates and 2 different angles are imaged. And the goal is to pick up a breast cancer before a woman can detect a lump because the prognosis is better. And screening starts at age 40 to 50, depending on guidelines that can vary between different breast and cancer associations. And mammography is a useful screening tool because studies have shown that mortality can be reduced by 40%. So this is what a mammogram looks like, and you can see that there's two views for each breast, so side to side and top to bottom. And then the breast is made up of glandular tissue that has milk ducts and lobules, and then supporting fibrous and fatty tissue. So mammograms basically detect masses or calcifications. And masses can be benign or malignant, and calcifications are specks of calcium that either appear benign or cluster in abnormal distributions. And both masses and calcifications appear white on the mammogram. So a radiologist, so the radiologist gives a report according to BI-RADS classification. And you can see from the chart on the right that a score of 0 means that the radiologist needed additional imaging or prior examinations. And then scores from 1 to 3 are reported as probably benign. And then scores of 4 to 5 are suggestive of malignancy with an abnormal lump or calcification. And then after that, a woman may be recalled and more imaging may be required, like a magnification view of the mammogram or an ultrasound, and then ultimately a breast biopsy may diagnose breast cancer. So mammograms are a useful screening tool, but there are limitations, such as a false positive, which is an abnormal looking mass that is not actually cancer. And 10% of women will be recalled for further testing, but of these women, only 5% will be diagnosed with breast cancer. So false positives create a lot of worry and anxiety for women and also increase healthcare costs due to the extra testing required. And then there's a false negative, which is missing a cancer on the mammogram. And 20 to 30% of cancers are missed on mammograms. And this may be due to human error, where either the radiologist misses it due to fatigue or distraction, or misinterprets an abnormality, or cancer may be difficult to see due to dense breast tissue. So now I'll talk about an early form of artificial intelligence called computer-aided detection, or CAD, which dates back to 1998 and is a pattern recognition software that identifies suspicious features on the image and brings them to the attention of the radiologist. So the radiologist first reads the mammogram and then adds on the CAD software. And here are some examples of markers that are added that are identifying a mass. So the CAD functions like a second reader on the mammogram. However, there are limitations of CAD, such as not being able to distinguish between benign calcifications or suspicious calcifications. And for every mammogram with 4 images, there's an estimated 2 false positive marks. So this means that some radiologists tend to ignore the CAD marks due to the high rate of false positives. And then on the other hand, they might ignore lesions that aren't even marked by CAD. So the question is there any benefit to using CAD technology? Well, a study was published in 2015 in JAMA Internal Medicine by Dr. Lehman and colleagues from Massachusetts General. And it looked at the performance of mammograms with and without CAD. And then the outcome was looking at mammography performance in terms of comparing the sensitivity, specificity, and the cancer detection rate between mammograms read with and mammograms read without CAD. So mammograms were interpreted by 271 radiologists from 66 facilities in the US from 2003 to 2009. And almost 500,000 mammograms were interpreted with CAD, and almost 130,000 mammograms were interpreted without CAD. And women were similar in age and family history of breast cancer and breast density between the two groups. And then women were followed for 12 months after their mammogram. So first, the radiologist would read a mammogram with CAD or read a mammogram without CAD, and then assign a BI-RAD score to the mammogram. And then scores of 0, 4, and 5 mean that the woman needed to be recalled for further testing. And the outcome could either be a true positive or a false positive. And then the sensitivity could be determined, which is the number of true positives divided by the total number of breast cancers. So this basically measures the ability of the radiologist to pick up a breast cancer that is truly on the mammogram. So BI-RAD scores of 1, 2, and 3 mean that the mammogram is probably benign and there's no immediate recall needed. So the outcome is either true negative, where no cancer was found after 12 months, or a false negative, meaning that the cancer was found within the follow-up period. And from there, specificity could then be determined, which is the number of true negatives divided by the total number of mammograms without cancer. And this measures the ability of the radiologist to say that there is no breast cancer when there is truly no breast cancer on the mammogram. So looking at the results, the screening performance was not improved with CAD on any metric that was assessed. So you can see in the top right corner that sensitivity was 85% with CAD and 87.3% without CAD. And this means that the radiologists tended to miss more cancers when using CAD, and this could be due to the fact that they weren't paying attention to the CAD markers or not even picking up on the abnormal areas that were not marked by CAD. Then you can see that there was no real difference in specificity, about just over 91%. And there was no real difference in cancer detection rate, with about 4 cancers per 1,000 mammograms. So CAD may have no clear-cut benefits to patients. However, CAD is still used in over 90% of mammography interpretations. And CAD also may be detrimental since it adds to the healthcare costs that insurers or patients have to pay. So now I'll talk about more advanced AI and mammograms. So AI is a more sophisticated technology than traditional CAD. And AI algorithms are able to narrow down a specific outcome like cancer or no cancer. And as I mentioned earlier, the many layers in the deep neural networks can detect complex features which can translate into cancerous masses. And the computer's algorithms evolve and get better with exposure to more training data. So a study was published in 2018 by Dr. Rodriguez Ruiz and his group from the Netherlands in the journal Radiology. And it compared the performance of radiologists reading mammograms on their own versus using an AI system for support. So the study looked at 240 mammograms, and half were from the US and half were from European sites. And then 100 of the mammograms had cancer and 140 did not. And there were 14 radiologists that read the mammograms. They read them once on their own, and then the same radiologists read the same mammograms with an AI system called Transpera in sessions that were about 4 weeks apart. And the sensitivity, specificity, and reading time was determined for each scenario. So here's an AI system workflow, and I just want to point out that the radiologist works alongside the AI application. So when using the AI system, the radiologist can first preview the mammogram by making note of the exam score, which is generated by the AI system, which is the probability of cancer in the mammogram on a scale from 1 to 10. And then a score of 10 would be the highest probability of cancer. And then the radiologist can then read the mammogram and get support from the AI system by clicking on any suspicious areas. And an area will have a suspiciousness score from 1 to 100, with 100 being the highest suspiciousness of an abnormality. Then the radiologist can get further help from the AI system, as all suspicious areas and calcifications can be highlighted. And finally, the radiologist can assign a BI-RAD score to the mammogram. And in this case, any score greater or equal to 3 would mean that the patient would need to be recalled for further testing. So looking at the results, the radiologists were able to improve their overall ability to diagnose breast cancer. So sensitivity improved from 83 to 86%, and specificity improved from 77 to 79%. And within the study, there was a separate analysis of the AI system's performance on its own based on the generated Transpera score. And it was similar to the radiologist's average performance to diagnose breast cancer. So this means that the AI system could also function on its own as a first reader to process mammograms, and then leave the abnormal mammograms for the radiologist to use alongside the Transpera system. So the graph on the left shows the reading time for each radiologist without the AI system versus the reading time with AI support. So each blue dot represents one of the 14 radiologists. And the reading time was similar in the unaided sessions and the sessions with the AI support. And then the average reading time was about 150 seconds. And then the graph on the right shows the Transpera score, which is the score for the likelihood of cancer in the mammogram, with low suspicion scores being 1 to 5, and then high suspicion scores being over 5. And for low suspicion exams, radiologists decrease their reading time, but they increase their reading time with high suspicion exams. So in a typical situation, when a radiologist would be reading a higher number of normal mammograms, their reading time would overall decrease when using this AI system. So the Transpera AI system has received FDA approval for its detection and decision support software as of November 2018, and it's now being used in a few private clinics in the US and in over 20 countries. And here's an example of a mammogram with a suspiciousness score of 44 in that particular region of the breast. So this may prompt the radiologist to recall the patient for further testing, like special views of that area. So AI holds a lot of exciting potential, but there are limitations. So first of all, medical legal concerns. So who would be responsible for a missed or wrong diagnosis? And there's a little cartoon on the right that kind of depicts this. So would it be the AI companies or the radiologists or perhaps both of them? And patients may not be comfortable having computer programs decide their fate, as it would be very similar to being in a driverless car or an airplane with no pilot. So there's a lot of hype around AI technology generated by the media and tech companies. So on the right is something called a Gartner hype cycle, which shows the path of new technologies. So after the innovation trigger, there's a peak of inflated expectations, followed by a trough of disillusionment when the technology doesn't live up to expectations. And then with time, there's growth in productivity. And you may be able to see it, but deep learning has reached its peak and is becoming more realistic in terms of its expectations. So there's also an issue with data sets. So computer systems rely on learning from large sets of data. And training data sets must be representative of the population, so it must include variations in demographics, pathology, and breast density. However, many training and testing data sets used in research are of small size and from single institutions. And the testing data set from the study by Rodriguez-Ruiz that I discussed with the AI system contained a disproportionately large number of mammograms with cancer. So the radiologists were made aware of this, and this may have influenced the way that the radiologists read the mammograms. And then there's something called automation bias, where readers over-rely on a computer-generated decision, which may lead to higher false positive and false negative rates. And this is the case in traditional CAD models. And then there's an issue with privacy, where even though data sets are stripped of personal data, there's still a risk of data leakage and possible re-identification. So I'll end off with future directions of AI and mammograms. So there are ongoing areas of research, including developing AI algorithms that can classify cancers that are life-threatening and require treatment, and those that can just be potentially watched. So this would enhance an AI algorithm from just saying that there is cancer or no cancer on the mammogram. And then another area of research is developing AI algorithms that can be used as a personalized tool to predict breast cancer risk using the patient's clinical data, like age and family history of breast cancer, along with the mammogram results. Then there's this new technology called breast tomosynthesis, which creates a 3D view of the breast and may replace traditional 2D mammograms since it's been shown to have greater accuracy at diagnosing breast cancer and is helpful in unmasking lesions in dense breasts. However, it does create more images, which means more burden on radiologists to interpret, but AI algorithms are already being developed to help radiologists with this. So AI not only stands for artificial intelligence, but also augmented intelligence, where AI can enhance or augment the capabilities of the radiologists. And most European countries have 2 radiologists read each mammogram, which is known as a double reader. However, in the US, a single radiologist reads each mammogram and then adds on the computer-aided detection system that I talked about earlier, otherwise known as CAD. And as I mentioned with the Transpera AI system, AI could process the normal mammograms and then leave the abnormal mammograms for the radiologist to interpret alongside the aid of additional AI. So, in conclusion, AI applications for analyzing mammograms can increase diagnostic accuracy for diagnosing breast cancer. And there was a recent study that was published this year from researchers from Google Health where they developed an AI system that outperformed radiologists in identifying breast cancer in mammograms. As well, AI can ease the workloads of radiologists, especially in the European countries that have 2 radiologists read each mammogram by having the AI system process the normal mammograms. And then along the same lines, AI can also relieve the burden of the monotonous readings of mammograms. And most importantly, AI can allow radiologists to spend more time with patients, which can ultimately lead to better patient care. So despite some of the limitations that I spoke about, AI has great potential for changing the way that radiologists interpret mammograms. So I'd like to acknowledge Professor Sutherland for teaching me physics over the past few years, and Dr. Susan Shepard, who also happens to be my mother, for teaching me about breast cancer and mammograms. And then St. Michael's Hospital in Toronto for allowing me to spend some time with them over the summer looking at their research. So this is my works cited. And are there any questions?
I had one question, Noah. First of all, that was a fantastic presentation.
Thank you.
And I understand that you had some hands-on experience in looking at mammograms. Can you tell us a little bit about what you looked for and how is that similar to what an AI is looking for?
Well, at St. Michael's Hospital, unfortunately, the research got delayed. But what I did was my job was to get rid of the patient information that was at the top right corner of each mammogram. And each mammogram also had a lot of empty space on it. For example, this image right here, you can see there's a lot of black space. So they wanted to kind of get rid of that extra space and especially the patient information. So they wanted me to put all the images through an algorithm that would kind of transform them. And they were looking, and that project was looking at breast density in mammograms, because breast density, the more dense a breast is, the more white parts there are on the mammogram. So, and masses and calcifications also appear white on the mammogram. So it's kind of confusing for the radiologist to look at that. And also, dense breasts increase breast cancer risk in the first place. So they were trying to use an algorithm to look at breast density and breasts on the mammogram. However, yeah, so the research got delayed, so I never really got to accomplish what they set me out to do, which is why I didn't really mention the research in my presentation. However, it did lead me to look at mammograms because I was interested in artificial intelligence and radiology, and that's kind of what narrowed down my topic.
Noah, I have a question. This is Dr. Gilmer. I was wondering, in changing the physics, we sort of used X-ray a lot over the last few years, and we used it in other areas of medical science where now we might do an MRI instead. Did you look into any information about changing away from X-rays and do some ultrasound or some other sort of way of trying to pick up on what maybe separating out a dense breast and unwanted cancerous tissue by using something that could do it better than X-rays?
Yes. So my presentation was specifically talking about mammograms, and women go for the test when they don't know if they have any problems with their breasts. So they're trying to pick up an abnormal lump. And I believe that mammograms, MRIs and extra testing like that is a lot more expensive and is more time consuming than a mammogram. So a mammogram is kind of like a quick way to get a baseline of if the woman has any problems in the first place. And then if the radiologist sees an issue, then extra testing may be required, like a breast and then a breast biopsy may ultimately diagnose breast cancer. So that's why mammograms are used in the first place.
So it's the best screening technique, it sounds like, right now.
Yes. It won't exactly be able to for sure determine that there is a breast cancer. There are better, more effective tests. However, they're more expensive and they're more time consuming. So the mammogram is kind of separates the woman into either having an abnormal lump or not. So it's kind of like, it kind of separates them, and then more testing is required later for the abnormal mammograms.
Thank you.
Hey, Noah, this is Dr. Han Ong. I guess it's hard to put weight on the two false readings equally, because a false positive, you typically will be a little bit more inconvenienced. You have to go for follow-up, a biopsy, a lot of stuff. So that is serious enough, but not as serious as I would think as a false negative, because if you misdiagnose something as being negative and it actually something is there, that could actually be more problematic. So with the CAD system that you have been talking about, does it particularly pay attention or prize more about solving that issue of a false negative than they would to fix a false positive? Or does it eventually treat these false readings as if they were the same in terms of their weight or seriousness?
Well, the CAD is more of like a way for the radiologist to kind of double check to see if there's any issues on the mammogram. So the radiologist actually adds on the CAD software after they preview the mammogram. So the computer aided detection system isn't really, it's more looking for any spots that it thinks is an abnormality on the mammogram, and it's not exactly I think the AI system Transparent in my second study, which also works alongside the radiologist, would do a better job at kind of what'd you say, the false negatives. It would do a better job at kind of maybe separating those out, if that makes sense.
Noah, this is Professor Rudd. Do you know if the patient as a consumer of like the healthcare system is notified at all if this system is being used on them, or are they alerted to this, or do they just assume their physician or radiologist is doing all this work?
To be honest, I'm not sure if they are. Like I said, CAD's being used in 90% of like mammography interpretation. So CAD's pretty heavily used. I'm not sure if that would be something that the radiologist would mention if it's so common. And then the AI system is different because it's not used as much, and it's kind of a new technology, and it works kind of like the CAD, where it works alongside the radiologist. So it's not making the make or break decisions exactly, if that makes sense. So I'm not exactly sure of that answer if the patients are informed.
This is just a 2-minute warning also. So if anybody has any other questions, they might want to ask.
This is Dr. Vaughn. I've got my last question. Great job, Noah. You mentioned the data sets, the sample size is one of the limitations. And why might that be, thinking from a biological perspective?
So the perspective I would think of is that the AI system is trained off of the images. So it's let me think about this for a sec. So
Right.
the more images that there are, the more experienced the AI system can be, and the AI system can grow in the future, the more images that it looks at, if that makes sense.
Yes. Okay. Thank you.
Thank you, Noah. And just a reminder to faculty that I think in 5 minutes we start the next presentation, and don't forget to send me the scores for Noah's presentation by noon tomorrow. So.
All right. Thank you.
Thank you.
Good job, Noah.
Thank you.
Thanks, Noah.
Thanks.
Thank you. Enjoyed your talk.
Thanks.
All right.
Okay.